This presentation is about the management of chronic haematological disorders in the community. I'm Jane Merciker.
And I'm Nano Suji. We're both consultant haematologists working in southwest London.
The overview of the presentation will cover the background, the reasons for change, outline of the pathway, and information on the two disorders, MGUS and CLL.
To put the problem in context, there is an increasing demand on secondary care, and that is in view of many changes, the changing demographic with an aging population, the fact that we are treating people and they're therefore living longer, and that more complex treatments are currently available. This is also in line with the Department of Health's initiative for care closer to home for patients.
How does this fit in with the National Cancer Strategy?
I think the focus has been on 5 fundamental shifts in the way we view cancer and survivorship. There's been a cultural shift with a focus not so much on illness, but really on health and well-being. And looking after patients in the community fits in more with that model. There's also a shift towards assessment, providing information and personalizing care planning. And again, care with local GPs would facilitate that initiative. The shift towards support for self-management is embodied in the whole concept that's being delivered here, in that patients will have to be empowered and will in many ways be leading their care or certainly initiating contact with healthcare providers in the community. And really and truly, we're moving away from a single model of follow-up to a tailored support that enables early recognition of signs of increasing disease. Lastly, I think there's a shift towards measuring experience and outcomes through patient-reported outcome measures. The long and short of this is that we are empowering patients to take the initiative to have their care closer to home, to focus on them being well, to focus on their health and well-being, particularly when they have chronic, stable haematological conditions.
Theoretically, that sounds good, but how are you going to ensure that patients continue to receive the same standard of care as they do now?
I think that's a very important question, and that was the whole basis for this work, which has focused on providing robust governance around the discharge of patients back into the community, but also providing GPs with guidelines as to when they may need to re-refer patients back to secondary care. This information is provided not just to healthcare providers, but also to patients, so that the triggers for re-referral will be housed not just within healthcare providers, but also, more importantly, with the patients. So these guidelines are to provide a clear pathway which is structured, which allows for comprehensive documentation. There would be uniformity and equity of access across the network, and this has been work that's been done across the whole of southwest London. We would contest that we would improve efficiency by removing non-urgent patients from secondary care. We would facilitate more urgent patients who need to be seen. We'll be able to accommodate new referrals, urgent suspected cancer referrals more quickly, but we'd still be able to see these patients, this cohort of patients, later on as and when needed by rapid access back into the system. This fits very closely with the philosophy of care closer to home.
So these are relatively uncommon disorders, and each practice might have only 1 or 2 patients. How can we be sure that GPs have adequate support?
Again, another important question. I suspect with time, GPs will become more and more familiar with managing these patients who, for the most, really just require clinical vigilance. And those are skills that all GPs will have. But we're supplementing those skills with a number of features. They will include a rapid access email box whereby GPs can actually email their questions. Patients will have abundant information at their disposal. There's also abundant information provided to primary care physicians, and a commitment that if re-referral to secondary care is required, that the patient will be seen in a timely manner, usually within 14 days. The consultant haematologists, like myself and Jane, are committed to providing workshops to help enable and facilitate GPs continue to manage these patients, and we propose that this whole system will be subjected to audit. So moving on, Jane, and looking specifically at the disorders, starting with MGUS and the slide entitled Monoclonal Gammopathy of Undetermined Significance. What exactly is MGUS?
First of all, I think it would be helpful to define the M protein. This is a monoclonal immunoglobulin secreted by an expanded clone of plasma cells and can be detected in the serum by immunofixation techniques. Monoclonal gammopathy of uncertain significance, MGUS, is when that protein is detected but without any visible sign of disease, such as you would find with myeloma, amyloidosis, or other lymphoproliferative disorders.
So Jane, can you tell us a little about the incidence of M proteins in the general population?
Well, the overall incidence is about 1%, but this varies very greatly with age. So in people in their sixth decade, it's only 1 or 2%, whereas patients over 90, 14% of patients can have an M protein. There's also a significant difference between different racial groups, and M proteins are twice as common in black people compared to white. There was a study looking at the number of M proteins found in an average district general, in fact at St Helier Hospital, which serves a population of about 350,000, and in 1 year 200 paraproteins were detected.
We often hear about M proteins in multiple myeloma and MGUS, but are there other conditions where these proteins may be found?
No, that's a good question. You're right, myeloma and MGUS are the most common conditions where we find an M protein, but there are other haematological cancers where they're found. For example, low-grade non-Hodgkin's lymphoma and Waldenstrom's macroglobulinemia are two such conditions. Another important condition that's often overlooked is amyloidosis. And indeed, there are other non-malignant conditions that may be associated with M proteins. For example, connective tissue disorders, SLE, rheumatoid arthritis in particular may be one of those conditions, and other infections, chronic hepatitis, for example, and HIV.
Diagnostic criteria for MGUS, asymptomatic myeloma, and symptomatic myeloma. Focusing mainly now on myeloma and MGUS, how can you distinguish between these two conditions? That's the crux of the matter, isn't it?
Yes, that's a very important question. Basically, the way that we differentiate MGUS from myeloma is by looking at the level of the M protein, and we tend to use 30 grams per litre as the cutoff. We also look at the number of plasma cells found in the bone marrow, and this is often the key factor. And as well as that, whether there is any associated myeloma-related organ damage as a result. So if a patient has plasma cells in the bone marrow greater than 10% or organ-related damage, we would classify them as having symptomatic myeloma. If the patient has high numbers of plasma cells in the bone marrow but no evidence of any organ damage, they would be asymptomatic myeloma. And patients with MGUS would have to have low levels of plasma cells and no evidence of organ involvement.
Table 3, myeloma-related organ or tissue impairment, ROTI. So focusing now again on this organ or tissue impairment, and the acronym ROTI is what is often bandied around. Could you elaborate on that for us?
The organs that tend to be involved in myeloma are mainly the kidneys, with patients often presenting in renal failure or with some degree of renal impairment. The other main problem is with bony involvement and patients presenting with pain, particularly back pain. Patients may also have hypercalcemia, that's another thing. And bone marrow failure, particularly anemia, is very common at presentation. Other things that are perhaps less well recognised may be recurrent infections. Patients will be prone to those because of the existing hypogammaglobulinemia, or rarely hyperviscosity if the paraprotein level is very high.
Could you tell us a little bit about how serious the complications from M protein-related diseases can be?
They can be very variable, but sometimes they may be life-threatening. The bony involvement, for example, patients can present with spontaneous fractures, but the most serious complication would be that of spinal cord compression, with plasmacytomas arising very commonly in that area of the spine, and patients presenting with neurological symptoms that can rapidly progress and require urgent referral for treatment. The other major life-threatening complication is that of renal failure. Again, quite a common way of patients presenting, and people may require urgent hemodialysis.
Jane, if an M protein is found, does it always have to be investigated? Because it seems to me that you need to balance the risk of over-investigating and generating patient anxiety against the possible benefits of finding a condition which needs to be treated.
That's a very good point. There are a couple of factors that will help us determine how far patients need to be investigated, and you're right, not all patients need extensive investigations. The concentration of the M protein and the type of M protein will give us some indication as to how likely that individual patient is to have myeloma. But all patients should have some basic investigations, particularly full blood count to determine whether there's any anemia, renal function to assess whether there's any renal impairment, and calcium. So those are baseline investigations. Of course, we need to take into account any clinical features to exclude any underlying lymphoproliferative disorder, and a history to investigate any possible back pain. Another thing that we tend to do as a baseline investigation would be to check for what we call Bence-Jones protein, or for some laboratories, serum free light chains.
How can we identify which patients need to be referred straight to a haematologist, assuming they've had an M protein found?
Well, any patient, of course, that has any serious symptoms that suggest maybe an underlying myeloma, patients that have abnormal renal function and high calcium levels, or anemia, for example. And then in terms of the M protein itself, if the M protein is high, for instance, in an IgG M protein of greater than 15 grams, or IgA greater than 10 grams, or any level of IgD, those are all patients that we feel ought to be seen in secondary care, and they will require further investigation, such as a bone marrow and skeletal survey to assess further.
Are you worried about patients with Bence-Jones proteins in particular?
Yes, because the light chains, which is basically what the Bence-Jones protein is measuring, are what is toxic to the kidney, and high levels of light chains can precipitate renal failure. So that's a particular group of patients where we're very anxious and they need close monitoring to try and prevent end-stage renal failure.
Given that the likelihood of progression in the low-risk group is so small, why should we bother monitoring these patients at all?
The risk is low. Overall, in this group of patients, we can say that about 1% of patients per year will progress to myeloma. But the purpose of monitoring is to detect those patients before they develop any irreversible end organ damage. So before they develop end-stage renal failure, before they have a pathological fracture. And that risk remains with the patient lifelong. So even when patients have been very stable over many years, they're still at risk of progression to myeloma, and that's why they need to be monitored continually.
I can understand the rationale for monitoring patients for life. Could you elaborate a little bit on how we should be monitoring patients?
Well, patients need to be monitored both from a clinical point of view and a laboratory point of view. So we need to be aware of any signs or symptoms that might represent progression. So we need to be asking patients particularly about bone pain, for example, fatigue or weight loss that might suggest a progression of an underlying lymphoproliferative disorder. And then the blood tests that need to be done will be blood counts to check to see that the patient hasn't become anemic, the paraprotein level itself and the serum free light chains, together with the renal function and calcium. So those are the regular blood tests that would need to be done at each monitoring visit.
My question to you, Jane, is there any way that we can stratify patients so that we know which patients with MGUS are perhaps less likely to require as intensive or as frequent monitoring and therefore be more aligned to monitoring in the community?
Yes, absolutely. There have been large population studies looking at patients who have M proteins to identify exactly those that are more likely to progress. And that's why, as I said to you in the previous slide, we use particular cutoffs for types of paraprotein in terms of the quantity. So for IgG paraproteins, if they're less than 15 grams, they're less likely to progress. The other thing that's very helpful in this setting is actually to measure the serum free light chains, because if these are normal or near normal, the likelihood of progression in patients with fairly low levels of M protein is very low indeed, and this is particularly the group that would be suitable for monitoring in primary care.
So we understand why we need to monitor patients. We understand how we need to monitor patients. Could you tell us a little bit more about how often we need to monitor patients?
Well, studies have shown that 4-monthly follow-up in the first year after identification of an M protein is probably advisable. If the patients are very stable, it would be possible to increase that interval in between the monitoring visit, possibly 6 to even 12 monthly. But patients always need to be aware of symptoms to report and to come sooner if they develop any of those worrying symptoms such as pain or fatigue.
I could argue, and correct me if I'm wrong, a particularly elderly patient or a patient with a very short arterial life expectancy and very small paraprotein, say below 5 grams per litre, that regular follow-up would not be required if myeloma and amyloid and lymphoproliferative disorders have been excluded. Would that be reasonable?
Yes, I agree. I think that would be reasonable. The likelihood of the patient actually coming to harm from their underlying M protein is very low indeed, and they're more likely to succumb from some other problem well before that catches up with them. So in those patients, regular monitoring probably is not necessary. It's possible that maybe if they're coming for something else, you might do opportunistic testing. But no, I would agree with you there.
I think, Jane, now we have a very clear understanding of why we should be monitoring patients, how often we should be monitoring them, and what tests we should do and what sort of clinical features we should look out for. My last question to you, therefore, is at what point should patients be re-referred to secondary care?
Well, at any time if they develop symptoms that are suggestive of myeloma, particularly back pain or bony pain of any sort, weight loss, recurrent infections. So those are the clinical things that would suggest referral is necessary. From the laboratory perspective, if the M protein is increasing by 25% or more, that would be an indication. And then at any time that there's a suggestion of end organ damage, so if the patient becomes anemic, if there's impairment of renal function or hypercalcemia, those would all be indications for urgent referral back to secondary care.
Thank you. I mean, again, it's a useful opportunity to just reiterate here that if there is any doubt, that GPs can always contact secondary care clinicians for advice.
Oh, absolutely. We would encourage people to get in touch and to, if they have queries, to contact us, and we'd be very happy to answer those questions. So we've identified stage A CLL as another haematological disease amenable to this model of follow-up. Nana, can you tell us a little bit more about CLL?
I suspect CLL is a condition that GPs are perhaps quite familiar with already. It is one of the most common leukemias in the Western world, and there are a number of patients who will have CLL as an incidental finding while investigating other disorders. Chronic lymphocytic leukemia is what we call a clonal B-cell malignancy. And what that means is that there's a group of white cells which have broken away from normal regulatory control and proliferate in an abnormal way, such that the white cell count in the blood increases. These are mature lymphocytes. They're small, mature lymphocytes that are abundant in the peripheral blood. CLL is actually a disease that is more common as you grow older, and it is actually more common in men than in women. The median age of diagnosis is often quoted to be in the 6th or 7th decade of life. In a very, very small percentage of cases, we know that there may be a familial trend to CLL, and this is the subject of a separate research project. What is important is that the cause of CLL remains unknown, and it is important to highlight to patients that it is nothing that they have done or not done that has caused this condition.
Nana, you've said that CLL is a relatively common condition. How are patients likely to present to the GP?
To be honest, I think most patients with CLL are diagnosed incidentally. Patients have a blood count for other reasons and are noted to have a raised white cell count, which on further interrogation proves to be CLL. Sometimes patients can present with what we call the classic B symptoms, which include weight loss, more than 10%, which is unexplained, fever, and night sweats. Another route of referral is for the patient with lymphadenopathy or enlargement of the liver or spleen, hepatosplenomegaly. Patients may present with marrow failure. If the marrow is full of CLL, they may present with anemia. They may present with low platelet count and bleeding. Rarely do they do that. Or they may present with recurrent infections for a multitude of reasons, not just because of a low neutrophil count, for example. They may also suffer with low levels of immunoglobulin and may be more prone to infections. Another category of conditions affiliated with CLL are the autoimmune conditions, and so you may have patients presenting with an autoimmune hemolytic anemia or an immune thrombocytopenia.
Nana, you've explained a lot of symptoms that patients may have at the time they present. How do we actually make the diagnosis of CLL, and are there any other conditions that might present in a similar way?
The diagnosis of CLL is usually made in the laboratory, where patients have a persistent lymphocytosis, and you often quote a level of greater than 5 by 10 to the power 9 per liter. The lymphocytes themselves have a characteristic morphology, and they show what we call clumped chromatin. So when we look down the microscope, we can see mature lymphocytes with characteristic nuclear appearances in keeping with CLL. That does not guarantee the diagnosis, however, because many other lymphoproliferative conditions can masquerade with similar morphology and can present with lymphocytosis. And therefore, to confirm a diagnosis of CLL, we require specialist testing in the form of immunophenotyping for that diagnosis. Bone marrow biopsies are not actually required. I think it's also important to mention another condition that we would call a B-cell lymphocytosis of uncertain significance. And this is where the morphological appearances are in keeping with CLL, where marker or immunophenotyping studies show a profile in keeping with CLL, but where the lymphocytosis is either smaller than 5 times 10 to the 9 per liter, or even sometimes within normal limits. And this is a condition that's being increasingly recognized, but we do differentiate it from CLL.
Nana, you've given us a very clear and detailed description of CLL, but can you tell us a little bit more about what you mean by stage A CLL?
The staging of CLL is done using a number of systems, and I think one of the most common systems is the Binet system. This allows us to use both clinical and laboratory data to assign patients into one of three stages: stage A, stage B, stage C, with each successive stage representing more advanced or progressive disease. We have good clinical data to suggest that patients at early stage CLL do not require treatment. And in fact, by treating them, we would actually adversely impact their outcome. So stage A CLL represents a condition where we simply need to adopt a watch and wait philosophy. In terms of actually staging your patient, you need to know their hemoglobin count, their platelet, and the number of lymph node areas that are involved. In general, patients who have less than 3 sites of involvement, who have normal hemoglobin, who have normal platelet count will be considered to be in stage A. And patients who start to reduce their hemoglobin or their platelet count in particular values less than 100 or 10, depending on your laboratory system, and platelet count of less than 100 would be considered stage C disease. Stage C is an indication for treatment, as would stage B. And patients in stage A may be considered for treatment if they show progressive disease. And by this I mean that there is a doubling in their white cell count or a falling trend in terms of their platelets and hemoglobin, or that they're developing progressive lymphadenopathy with B symptoms.
Nana, you've described how patients can progress in terms of their lymphadenopathy or development of anemia or thrombocytopenia. What other complications might we expect in patients with CLL?
So again, patients with CLL can have complications which are affiliated directly with their disease. For example, transformation to a high-grade lymphoma, or sometimes more rarely Hodgkin's disease. But more commonly, the complications are affiliated to the disease. So there's an increased risk of infection, particularly with bacterial infection for patients who have low levels of immunoglobulin. But there may also be T-cell dysfunction, which can predispose patients to viral infections, particularly with diagnoses such as zoster. Autoimmune conditions we've touched upon briefly, and this can become more overt as the CLL progresses, so that patients can present with rampant hemolytic anemia, or in some cases with ITP, where they may have bleeding manifestations. We also recognize that patients with CLL have a higher risk of other malignancies, including simple skin malignancies, which may be more common.
Nana, you've described a number of complications that might happen in patients with CLL. At what point should patients be referred back to secondary care?
I think it's worthwhile saying that patients who are being monitored with CLL should be probably seen every 3 months initially, until an understanding of the pace of their own individual disease is gleaned. Thereafter, if things remain stable, it's very reasonable to widen that interval. In terms of symptoms and tests that would precipitate a re-referral back to secondary care, certainly if there is new onset of B symptoms, fever, night sweats, unexplained weight loss, patients should be sent back. If there is progressive lymphadenopathy or bulky lymphadenopathy, patients should be referred back to the hospital. New onset or again progressive hepatosplenomegaly would be another indication for contacting secondary care physicians. Patients with recurrent infections need to be seen because this too can be a hallmark of progressive disease. And we've already touched upon autoimmune complications such as autoimmune hemolytic anemia and ITP, which if they are manifestations of the CLL, could benefit from treatment of the underlying lymphoproliferative disorder. Lastly, in terms of monitoring blood count, if there is a falling trend in hemoglobin or platelet count, definitely I would be on the phone to the secondary care facility to discuss further. And certainly if the hemoglobin is less than 10 or platelets less than 100, re-referral to secondary care is warranted. In terms of the lymphocyte count, one of the triggers for re-referral would be the lymphocyte doubling time. And certainly if a patient has a doubling time of 6 months or less, they should be treated. So what we would be saying to GPs is if the doubling time is 12 months or less, certainly that's a point at which you can re-refer so that secondary care decisions around treatment can be made.
Nana, is there an absolute level of lymphocyte count that you would be concerned about?
That's actually a really good question, Jane, because many physicians, both in primary and secondary care, do focus on the total lymphocyte count. Whereas as long as the hemoglobin and platelet count are fine, as long as your patient is fine, the absolute lymphocyte count does not worry me. And I have many patients with lymphocyte counts of 300 who are very well, who I continue to monitor. So I think it is something that's not within your comfort zone to see a count that high, but as long as all the other clinical and laboratory features are stable, there's not a reason to get concerned.